I thank everyone for the opportunity to discuss what I feel is this very important topic and what is a very important opportunity for us all to make differences, not only in the generation of mothers that we care for now, but possibly the generation of mothers that are created by these pregnancies. So by the end of the session, we will hopefully have learned what's new in the diagnosis of type 2 diabetes, understand that treating gestational diabetes now unequivocally makes a difference in pregnancy outcome. We will summarize the results of an important trial that looked at non-gestational diabetic patients and how many fat babies were delivered. Then understand the basis for new diagnostic guidelines that have been accepted by Sweet Success, and then finally to appreciate the preliminary data that we've obtained at UCSD comparing the two diagnostic regimens. Now this map is not a surprise to anybody because it describes the global obesity problem as of about 4 or 5 years ago, and the darker colors, we're not surprised to see the United States is leading the way, but many countries that formerly we never thought as having an obesity problem are surging forward, if you will, not only Australia and the Middle East, but India and China. And then if you take America, the United States, you can see here the darker the color, the more obesity. And we're talking about, in some states, more than a third of individuals actually being obese. And even though we all pride ourselves perhaps in being exercise and dietary focused and so forth, you can see that even in the state of California, for example, Oregon and Washington, where everybody rides bikes and tries to live healthy, up to a quarter of individuals are obese. It's a bit shocking. And of course, where obesity goes, diabetes goes, and this is the percentage of the U.S. population diagnosed with diabetes as of around 2008. You can see that trend line, and you can see that the trend line is shooting up, so that presently with diagnosed diabetes, it's approximately 7 to 8% of the U.S. population has diabetes now. And in fact, there's usually an equal number of people with diabetes that have not yet been diagnosed, and that means about 1 in 7 or 1 in 8 people in the United States have diabetes. This is a public health problem of enormous importance. And of course, where overt diabetes goes, we know that gestational diabetes is not fake diabetes. It's real diabetes that goes away when the placenta comes out and the baby delivers, but almost always comes back within 5 to 8 years, because it's not that you catch diabetes from being a gestational diabetic. Having a pregnancy where we find gestational diabetes tells us that there is a destiny, there is a process that's already long underway to make people fat and to make them have diabetes. And you can see that in the upper curve there, where women over the age of 35, you're talking about now gestational diabetes being 8, let's call it 8%, because I want you to keep that in your head as we go forward and look at what percentage of women will be diagnosed with gestational diabetes if we change the diagnostic criteria. Now the criteria for type 2 diabetes, as described by the American Diabetes Association, are first based on hemoglobin A1C of more than 6.5%, and that correlates with an average blood sugar of around 130 milligrams per deciliter, which is really quite high on an average basis. Another way to diagnose it is to catch someone with a fasting blood sugar of 126, and I think we all recognize that's pretty high, and then or during a 75-gram oral glucose tolerance test, which is the way to diagnose diabetes worldwide, having that 2-hour value over 200 makes one have the diagnosis of type 2 diabetes. Now, I'm emphasizing this because you're going to see shortly that the new recommendations are to test every pregnant woman at the start of her pregnancy for the presence of type 2 diabetes. Because remember, of the women who actually have it, only half of them actually know it. What do you do with the patients who have clearly abnormal blood sugar values, let's say over 100, but less than the threshold of 125 for fasting, or hemoglobin A1C in this middle zone, clearly abnormal with blood sugars that are really high, but not officially making the diagnosis of diabetes, we call this prediabetes. American Diabetes Association has created this criterion in order to identify people who will develop diabetes probably within the next 5 years. Why do we want to label people with prediabetes? Because this is a label which allows us to change health behaviors. This is a label which can change the likelihood of us developing diabetes within the next 5 years if we change our physical activity and dietary intake. But if you take the total of diabetes and prediabetes, where let's say roughly 10% have diabetes, remember there's another 5 or 8% out there who have it but we don't know it, and then 19% of prediabetes means in the United States, either with prediabetes or diabetes, almost a third of the U.S. population has this condition. And when you think of what this is going to do for our healthcare costs over the next 2-3 decades, if we cannot make a change in this avalanche of fatness and diabetes, it's going to be extremely expensive. Now, you know, Michelle Obama is focused on the problem of childhood obesity because the obesity that we've described in the United States is not just among adults, it's actually amongst children. Here you see the results of a series of 4 decades of the NHANES surveys with children you see here in groups age 2 through 5, 6 through 11, and 12 through 19 in these surveys. And you can look and see what has happened to the presence of diabetes through this time frame from the 70s all the way up to the present. And you can see this purple bar, which is the most recent assay, has teenagers. Basically, 1 out of 7 have obesity. And it's through, all these curves have rocketed up. But the thing that I find so interesting is the group that has risen the most on a percentage basis over this past period of time are these children aged 2 through 5. Now, could it be that we are just overfeeding these children, that are well-intentioned but poorly controlled mothers are giving them too many fatty foods and letting them sit around and play too many video games? Or, in fact, are these children already programmed to become fat because they lived inside their mother during a diabetic pregnancy? They may have accumulated body fat inside their mother because of the presence of gestational diabetes that has destined them to become fat as children in school, and then teenagers, and then as adults. Here's an example that makes me think this might be the case. Here you have a beautiful study conducted among Native Americans who were very carefully studied in Arizona, and this 2 cohorts of children, one group in the light gray bars, their mother did not have diabetes during the pregnancy. And then the other group, shown in the black bars, the same mother, but later had a baby when she did have diabetes. And look at here's body mass index, and here is the difference between these children. As they go forward in age, you can see that the children whose pregnancies did not have diabetes in it, they really don't increase their obesity at all. But there is a relentless increase in obesity in the children who were exposed to diabetes when they're inside their mother. Now, by the way, I would point out this last set of bars over here indicate, that if you work hard enough, even this group, who were not perhaps programmed inside their mothers to become fat like their siblings, can become fat later if they try hard enough. But I think this is the first wonderful evidence from Dr. Davalea that we can be programmed in utero to develop diabetes by being exposed to something unique, not good, about our mother having diabetes. And here is a better example. Here is Dr. Boney and Vore, and they are looking at children at approximately age 7. They are looking at what's called the metabolic syndrome, not just obesity, not just diabetes, but hypertension and hyperlipidemia. That's what the metabolic syndrome is. And we're looking at 7-year-old children with all of these things called the metabolic syndrome. Now, draw your eyes first to this little bar over here that's approximately 18 to 20%, in which the baby was born normal size, and the mother we know did not have diabetes. Then let's look what happens if, and these are at age 7 now, this is the likelihood of having metabolic syndrome. We almost double the likelihood that the child will develop metabolic syndrome by age 7 if, in fact, even though the mother did not have diabetes, but the child was fat at birth. Okay, so maybe, and we do know that fat mothers can help build fat babies even without diabetes. But look at this one. Here are mothers with gestational diabetes who, through dietary control and other measures, had a baby that was normal size. Look at that. The likelihood of metabolic syndrome is almost the equivalent to the mothers who didn't have diabetes but who also had normal-sized babies. But God forbid, if we should have gestational diabetes and a fat baby, look at almost 50, this is per 1,000, so it's really 5% of these 7-year-old children having the metabolic syndrome. Because we would say the only thing that's different about these pregnancies is there was gestational diabetes. And it does suggest that perhaps controlling blood sugars or going through some kind of a therapy, even with gestational diabetes, may reduce the likelihood of developing these bad things in childhood. Similar results here, I won't go into them in great detail, but simply to say that the blue bars are mothers who had gestational diabetes, and these are their children at age 27. And if you will look at fasting glucose abnormalities, you will see if the mother had gestational diabetes, the chance that the child will have high blood sugars at age 27 is really triple or almost quadruple the level that occurs among normals. So, you know, whether it's central obesity, hyperlipidemia, hypertension, all these parts of the metabolic syndrome are accelerated by being exposed to diabetes inside your mother. Okay, how does this happen? Well, so here's our mom. She's trying to take good care of herself. She's taking following her diet. Now she's been diagnosed with gestational diabetes and she's got insulin resistance. But we know that whatever happens to the glucose here on the mother's side comes right across the placenta into the fetal compartment. So if we had that, no, I gave up. I just had some big bag of French fries, and that glucose comes right across like an avalanche, right across into the baby's circulation. It can't send it back. It's got to take care of this glucose and store it some way. So we arouse the insulin from our pancreas, and we store all those extra calories right along our backbone, right along our chest, right where it will be difficult for us to be born. Furthermore, that avalanche of glucose will be difficult to store. It will actually require extra energy we'd normally use for other things, and you can actually measure in a fetus being exposed to excessive glucose a reduction in the oxygen inside the fetal compartment. And this, of course, has permanent changes, as we've already seen, in how the child is going to grow up. It also has temporary changes when the baby's born with problems with hyperbilirubinemia and hyperviscose blood. Now, Pat Catalano has kind of put this together, showing that there's an intergenerational transmission of obesity. Because if we start ourselves by being obese and therefore at risk for gestational diabetes, we have extra maternal fuels that cross right across the placenta into the baby. The baby develops obesity in utero, which then it develops as a child, then it as a teen, and then sure enough, those same fat, overweight little babies become people who have children. They themselves have gestational diabetes, and around we go again.